The earliest reported cataract operations used no visual support. Subsequently, lenses, microscopes, make-view and side-view films were employed. This video will demonstrate how cataract surgery can benefit from using endoscopy. Using an endoscope, it is possible to view the incision. We observe the exact time and location that the blade penetrates the cornea. We can identify the viscoelastic substance filling the anterior chamber, thus making it possible to perceive when the anterior chamber is completely filled. The presence of bubbles in the viscoelastic layer facilitates identification. Though not providing a perfect tridimensional image, capsulorhexis can easily be achieved using an endoscope. Its advantage is that it enables visualization even when the tear extends beyond the pupil, thus facilitating recovery from capsulotomy, even when it is at risk of expanding. Lack of transparency of the cornea ceases to present an obstacle in cases of glaucoma. Another advantage is that it dispenses with the need for red reflex, thereby offering a solution in cases of hypermature cataract, making it unnecessary to use stains. Hydrodissection may be performed. However, this may hamper perception of the wave of liquid reaching the posterior portion and may cause the epinucleus to rise and obscure the field of vision. Observing the phacoemulsification probe from the front using an endoscope has proven most revealing. In an initial phase, the pointer is positioned downward to concentrate the ultrasound and remove the cortex, so a groove can be made while being monitored by the endoscope. We can evaluate placement of the probe in relation to the cornea, the cataract, the capsulorhexis and the posterior capsule during fragmentation of the nucleus and also during removal of fragments. The phacochop technique and Nagahara chopper movements employed to break down fragments that occupy a major portion of the anterior chamber pose a risk of endothelial touch. After breaking the nucleus, fragments were observed to be moving at much greater speed in comparison to the view from the microscope and can better be assessed using the endoscope. In terms of followability and holdability, the Osiel probe proved efficient when fragments were very rapidly emulsified. Endoscopic access to the region of the capsular bag enables removal of the entire cortex, including parts hidden behind the iris or below the incision, thus ensuring that aspiration is complete. Polishing of the capsule may extend to the entire bag, preventing its contraction, which is especially of interest when an accommodative lens is to be used. We can observe the injector penetrating the corneal incision. The interocular lens to be introduced is an Alcon aspheric single-piece lens. The haptic loops may be verified even before they reach the anterior chamber. The IOL is then positioned below the anterior capsule and, as it unfolds, it takes its place in the capsular bag. The haptic loops loosen progressively from the optical body, principally through maneuvering and viscoelastic accommodation. Using endoscopic imaging, it is possible to certify that the IOL is in the bag, even in cases in which the capsulotomy is not continuous. The haptic loop of the IOL occupies the extremity of the capsular bag, keeping a distance from ciliary processes. Sulcoflex. The Sulcoflex IOL, upon being injected, finds less space to unfold since the capsular bag is already occupied by another lens. The IOL is rotated until the haptic loops, with their undulated design, are positioned in the sulcus. Whereas from behind we observe the single-piece IOL in the capsular bag, from above we see the finer haptic loops of the sulcoflex positioned on the sulcus. The folds of the haptic loop remain in contact with the sulcus along practically its entire length. With the crystal lens accommodative IOL, the position of the haptic loops can be verified using an endoscope to ensure they are correctly positioned in the extremity of the capsular bag, thus ensuring that the accommodation will be preserved. It is possible to verify the two haptic loops and even to move the IOL with the probe, so as to ensure that it settles in the best position. In this case, one haptic loop of the capsular ring is in the bag and the other outside. It is possible to determine the exact moment when the ring protrudes from the capsular bag. Only by using endoscopy is it possible to confirm the position of the capsular ring. The body of the ring is positioned behind the ciliary processes in the pars plana region. The capsular bag in the area of subluxation is all wrinkled. The vitreous base can be observed where no trace of cortical material can be detected. We found the haptic loop of the IOL within the capsular bag in the subluxated region far from the ciliary processes. It was possible to conduct maneuvers to attempt to reposition the capsular ring using a Sinski's hook. Endoscopy has proven very useful during scleral fixation, especially in guiding the needle to reach the region of the ciliary sulcus and in identification of vitreous adhesions and fragments of the cortex. If the intended spot proves unsuitable, it is possible to correct it prior to effecting perforation of the eye, thereby increasing precision. Lastly, the thread is secured to fix the IOL in the correct position, and this can be verified endoscopically. Combined surgery for cataract and glaucoma offers excellent opportunities for the use of endoscopy. The transparency of the capsular bag can be used to obtain access to ciliary processes. These can then be treated by laser, preserving the conjunctiva without requiring suturing and presenting very low indices of complications. In conclusion, endoscopic images can assist in cataract surgery, not only by providing lessons, but also by enhancing diagnostics and treatment.